Welcome back, and thank you again for joining us this morning. It is my pleasure to introduce our next speaker, Dr. Leonardo Tozzi, a postdoctoral researcher at the PMHW. Dr. Tozzi has played an integral role in the Human Connectome Project, a large multi-site effort to map human-brain connections in health and disease. Here to present on connectomes and big data for mental health, I welcome Dr. Tozzi.
Thank you very much for the very kind introduction. And it is both a pleasure and an honor to be here today presenting at the symposium. Today, I'm going to talk about connectomes and big data and how we use them at the Stanford Center for Precision Mental Health and Wellness. My takeaway message for you today is the following. At the Stanford Center for Precision Mental Health and Wellness, we combine brain connectomes with other big data to improve the diagnosis and treatment of depression. And you can see in this sentence, there's a lot to unpack. So in my presentation, I will walk you through each single aspect of this sentence. First of all, we will define what is a brain connectome. Then I will move on to describe the big data we collect in our center and how we integrate it. And finally, I will give concrete examples of how we use this data to answer clinically relevant questions. So first of all, what is a connectome? And I would like to take a really huge step back, in fact, to the edge of our galaxy. So there are 250 billion stars in the Milky Way, our galaxy, and that's a lot of stars. And to give you a comparison, inside of human brain, we have more than 100 trillion synapses. And so this is orders of magnitude greater than the number of stars we have in our galaxy. And this is what we mean when we say the human connectome, that is the ensemble of brain connections within a human brain. And when I say connections, I'm speaking of primarily two types of connections. We have structural connections, which you can imagine as the physical wires linking together different portions of your brain. And we have functional connections, which means that different parts of the brain work together to achieve the same function. So that's a lot of connections right there. So how do we quantify these connections? In 2009, the NIH launched a very large collaborative project called the Human Connectome Project. And you can think of the Human Connectome Project a bit as a homologous project to the Human Genome Project. The Human Genome Project aimed to quantify the human genome, and the Human Connectome Project aims to quantify the human connectome. And you can see in the map, there are a lot of sites involved in this project, both in the United States and in Europe. And if you look at the leftmost corner of the United States map, there's a little pin in the San Francisco Bay Area, and that is us. So we are a member of the Human Connectome Project, and we focus especially on quantifying human connectomes in anxiety and depression. So pragmatically, how do we quantify a connectome here at Stanford? So as Dr. Williams already mentioned, we use a technology called functional MRI. This is a machine that allows us to take snapshots of brain function in time as participants perform a wide array of tasks. These are very large images, and after they have been collected, they get uploaded to our cloud storage systems and sorted in a database. After that, we are able to conduct sophisticated computational operations on this data, thanks to the Stanford high-performance computing clusters. And we are very grateful for the support of the Stanford Research Computing Center that allows us to perform these very computationally expensive operations. At the end of these operations, we can summarize the function of brain circuits as numbers. And that is what we study and investigate in our experiments. Depending on the brain circuit we're interested in, we can ask people to perform different tasks inside the scanner. For example, Dr. Williams already mentioned this, the default mode circuit is a circuit that's especially active during free thinking. So what we ask people to do in the scanner to capture the activity of this circuit is to just let their mind wander as it naturally does. By contrast, the negative affect circuit is a circuit that's especially active when people are experiencing negative emotions. To probe this circuit, we simply show participants in the scanner, for example, images that are designed to elicit fear or anger. Again, another example is the cognitive control circuit. This circuit is especially involved in cognitive tasks. So what we do is we ask our participants to perform in the scanner some cognitively challenging tasks. to probe this circuit. As you can see in the picture, we have a full menu of circuits we can probe, and each one of them is engaged by a specific task. So what we do is usually we let our participants perform all of these tasks, and then we obtain quantifications of the function of each of these circuits. So moving away from circuits for a little bit, I would now like to talk about big data at the center in general. And this big data we collect can be grouped into 4 large bins. I've already talked about brain circuits, but I would like to show you that we also have data on cognition, genetics, and of course, symptoms, which is crucial for our work. I already mentioned that we have data about brain circuits, but just to give you an idea of the scale, we currently have more than 6,600 brain scans, which amounts to more than 3 months of continuous nonstop scanning. Concerning cognition, we have more than 5,200 standardized clinical cognitive tests. And these tests measure cognition along several different dimensions. It could be attention, it could be executive function, it could be planning, anything. Moving on to genetics, we have more than 2,700 DNA codes to perform genetics experiments and to link genetics and the brain. And finally, of course, we have a very large data set of standardized clinical questionnaires, more than 7,000, that assess various symptoms of depression, anxiety, and other disorders. We also have thousands of free-form descriptions in the words of the participants themselves to do some natural language processing experiments as well. So our goal in the center is really to find ways to integrate this data, and in particular, highlighted here in red, how to relate the other types of data to circuits. And of course, we welcome collaborations, and we work collaboratively a lot in the center. And here I am showing 4 of the key questions we think about when looking at this data. The first question is, what brain connections can we measure that are really important? I said we can measure thousands of connections, but which ones do really matter for the problem at hand? The second question is, how do these brain connections relate to symptoms? The third question is, can we identify biotypes of depression and anxiety? Meaning, can we group people with depression and anxiety into different groups based on their brain function? And finally, what are the best biomarkers we can discover that can predict clinically relevant outcomes? And in the next few slides, I'm going to give you an example of a study we conducted over the past couple of years for each one of these questions. So for the first question, what brain connections are most important? I would like to show you this data from a study we published last year. And here we're focusing especially on one very specific question, which is the question of reliability, meaning in a large sample of participants that were scanned at 2 time points, and here we're talking about around 1,000 people, which ones are the brain connections we can measure reliably? And we saw that the cognitive control circuit is extremely reliable. And so we can quantify these connections very precisely. And this makes this circuit a promising candidate for biomarker development. Moving on to the second question, how do circuits relate to symptoms? What I'm showing here are the results of a collaborative study done with the Department of Statistics here at Stanford, in particular, Drs. Trevor Hasty and Elena Tuzzilina. Together with them, we developed a novel algorithm to link, circuit function and symptoms. Thanks to this algorithm, we were able to find that circuit function in the negative affect circuit is correlated with symptoms of depression and anxiety in a large population. To answer the third question, can we identify more biotypes of depression and anxiety? I am showing here some preliminary data of a study that we're currently conducting. In this study, we leveraged a large sample of participants with depression and anxiety. And we probed their circuit function with an array of tasks, as I have shown before. And then we looked at the brain function of these participants, and we grouped them into distinct groups based on their circuit dysfunction. And what we found is that we could separate these participants into 3 distinct groups. And now we are currently in the process of analyzing how these groups differ in terms of clinical characteristics and treatment response. Finally, to answer the last question, what are the best biomarkers to predict outcomes? I would like to show you some results of a study we published a year ago now. In this study, we leveraged the data from a clinical trial. In this clinical trial, some depressed participants were treated with antidepressants, and they were scanned before and after their treatment. Also, a group of healthy controlled was scanned before and after a certain time to match the scans that were conducted in the depressed participants. And once again, here we focus really on the cognitive control circuit, and we show that the participants that at baseline had lower cognitive control circuit function and lower mood improved after treatment. And importantly, not only did their symptoms improve to reach the level of healthy individuals, but also their circuit function was restored and increased back to the level of healthy individuals. So this study is an example of how we can link together symptoms, brain circuit function, and clinical outcomes. And Dr. Hack in her presentation is going to focus a lot more on studies like this one. So this concludes my presentation, and I would like to spend the last few seconds thanking a lot of people. So first of all, I would like to thank the team of the Human Connectome Project for Disordered Emotional States, which is our branch of the Human Connectome Project here at Stanford. And of course, I would like to thank the staff of the center as a whole. This is really an extraordinary team to be part of, and none of this would be possible without the great collaborations that we run with each other. And finally, I would like to encourage you to participate in our research, to reach out and partner with us as we tackle these exciting questions. And I would finally like to really thank you for your attention. Thank you very much. I'll take any questions now.
Thank you, Dr. Tassi, for walking us through how the Human Connectome Project is combining brain connectomes with other big data to improve the diagnosis and treatment of depression. Let's move into the Q&A portion of our program. If you do have any questions, please do add those in the Q&A section. In the interim, I can start by asking Dr. Tassi, how big is a functional brain image?
Yes, that's a great question. So functional brain images can be very large. You have to keep in mind that what we are recording is the entire brain in time. So we have basically a three-dimensional image, and we have several three-dimensional images which correspond to snapshots of this brain in time. So we can measure the brain with really high precision, meaning that for each brain, we get around 100,000 voxels, which are the equivalent of three-dimensional pixels. So 100,000 numbers, basically, for each snapshot of the brain. So you can think that if you, for example, acquire 100 of these snapshots in time, and usually that's, we would acquire even more than 100, you can see how each image is basically millions of numbers. And so storing these images and, doing computational work with them requires considerable resources in terms of like storage, but also computational power.
Fascinating, thank you. We actually have a question in our chat. Hi, Dr. Tassi. I'm curious, what are some of the biggest challenges when it comes to your research? Thanks.
I would say that one of the biggest challenges is the integration of different types of data, as I've shown here. So a lot of our efforts go into thinking about how we can link in a meaningful way these different types of data. Clearly, as we have millions of possible data points to choose from for each of these modalities, right? So we have millions of numbers from the imaging. We have possibly thousands of numbers from the symptoms, thousands from the tests. So a lot of the challenges are into integrating this data. And that's why we are very grateful for all the collaborations we have with statisticians, data scientists, to make sure that the links we find are not spurious and that they can be robust enough that we're confident about them. That's a great question. Thank you very much.
Thank you. Our next question from the audience is, are there any cases when symptoms improved, but the circuits don't look improved? If so, how does one interpret that? Thank you.
That's really a great question. Thank you for asking that. So the thing yes, there are cases like that. So the way we think about it is depression is a very heterogeneous being. Right now, we are assigning the label of depression to a lot of people who might have different dysfunctions in their circuits. So it might be the case that when we look at one circuit and we see like that people improve, but the function in that circuit doesn't change, it might mean that in that particular person, the dysfunction was originating somewhere else in the brain. And so one of the challenges we face now, and that's one of our goals, is to really try and parse, this large population of people with depression into bins where we can really see in each individual which is the brain circuit that is affected, and then deliver a treatment that is targeted to that specific brain circuit. And that's something I think that you will see more about in Dr. Hack's upcoming presentation. Thank you very much for your question.
Thank you. We have two more questions. We have time for these last two. Our next one is, thank you so much for your great presentation. I have a question about the terminology, specifically the term connectome. The suffix "ome" generally describes a more or less permanent set of constituents of a system, considered collectively, and is assumed to be invariant and context independent. Like the base pairs in the genome, would it apply more to the diffusion MRI-based circuits or not fMRI-derived circuits? Thank you.
That's a great question, and I'll try to answer it in a shorter time. So you are absolutely right. So we can think of connectomes as coming from different sources, right? You mentioned diffusion, which is what we use to quantify physical connections, but using fMRI, we can quantify functional connections. Some of these connections are very stable, as you mentioned, like the structural connections, but some of those other connections can be also dependent on what the person is doing at the moment. Clearly, when you look at functional MRI, a lot of the function of the brain has to change as the person is, for example, doing a task. And so we still think of those connections as connectomes. And I would say that, connectomes can also change in time if you define them this way. So one of the challenges we tackle, and this was part of the study I've shown here, is like, how can we find the balance between what changes enough to make sure we can interpret what's going on in the brain? Because clearly, if you're engaged in cognitive control, something in your brain is going to change. So, and that's the signal we're interested in, because that's the signal we want to capture. So we want it to change. But how do we make sure that it's not changing so much that it's like unstable and cannot be interpreted as a characteristic of the individual, but just as, random fluctuations? And in this study, for example, we directly tackled this question by finding that the cognitive control circuits is a functional circuit, and it does change in time, but within an individual, you can still gather information that's proper of that individual and is not affected by random fluctuations. So it's still a measure of something of the individual, even if it's changing in time.
Thank you. We do have a few more questions, but we'll move those to the panel discussion later this morning. Thank you, Dr. Tassi.
Thank you very much
for your time. So it is with my great enthusiasm that I introduce our next speaker, Dr. Laura Hack, clinical instructor and founding director of the Stanford Translational Precision Mental Health Clinic. Her focus is on identifying targeted treatments for subgroups of depressed patients. Here today to present on precision psychiatry and novel therapeutics informed by neuroscience, I welcome Dr. Hack.
Thank you so much, Hasna, for the kind introduction, and thank you all for coming. It's really an honor to be presenting as part of this distinguished panel. I'm thrilled to be here today to discuss the work we've been doing in the center on the clinical application of neuroscience-informed precision psychiatry. So while the implementation is more complicated, the goal of precision psychiatry is simple. It is to relieve patient suffering by matching preventative strategies and treatments to individual characteristics. Some have expressed concern, and rightfully so, that this high-tech approach will replace our current approach and take the human touch out of psychiatry. At the center, we don't see it as replacing our current approach to patient care, but instead complementing and improving upon it. And to illustrate this, I'll discuss precision psychiatry in the context of our current practice for depression, which is the focus in our center, in 3 phases: data gathering, treatment decisions, and monitoring and prevention. So when a patient first presents with depressive symptoms, we currently already gather clinical information from multiple sources, including interview, observation, and sometimes questionnaires. We assess environmental exposures, and we may conduct limited biological measurements, such as thyroid hormone, to rule out medical causes. Precision psychiatry adds to that multiple other sources of data that we can now measure due to technological advances, including pharmacogenomics, inflammatory markers, and functional MRI, which you've heard about from Dr. Williams and Dr. Totsi. So in standard care, we then select among the first-line evidence-based antidepressants based on a limited number of factors, such as clinical experience or patient preference. With precision psychiatry, the vision is to match treatments with individualized profiles. So with this approach, we may start with therapies that are traditionally only considered later, such as TMS or transcranial magnetic stimulation or ketamine. Finally, in terms of prevention and monitoring, in the current practice, we typically follow up with patients every 1 to 3 months. With new technologies, we will now be able to monitor patients with real-time data collection, such as some of the sensors that Dr. Williams described. And this will allow us to intervene sooner, potentially before someone relapses. So at the center, we truly believe it's the right time to start applying precision psychiatry to the clinic. And we feel fortunate that the National Institute of Mental Health and Veterans Affairs agrees. So the NIMH develops a strategic plan every 5 years. And one of the objectives of the 2020 plan is tailoring existing interventions to optimize outcomes. Precision psychiatry is also a priority for the VA. In the fall of last year, Congress passed a bill called the Precision Medicine Initiative with the aim of identifying and validating brain and mental health biomarkers. At the center, we also believe that Stanford is the ideal place to be implementing precision psychiatry in the clinic. This is because precision health has been a focus at Stanford for many years, with Dean Miner leading the charge, as exemplified in his eloquent book, which Dr. Williams has mentioned. This text, High Tech and High Touch, is pulled directly from the Precision Health website at Stanford, and emphasizes the key point that while precision health and psychiatry involve advanced technologies, at Stanford and in the center, we are making every effort for the human aspect to remain. So in focusing on depression specifically, we know that a major issue is that it is highly heterogeneous, symptomatically and biologically. But for the most part, our first-line medication treatments have the same mechanism of action. As I've mentioned, we have some ways of tailoring treatment, but it is mostly a trial and error process, selecting among first treatments, then among novel and alternative treatments. This results in only about 30% of patients remitting on the first treatment and 60% after subsequent trials. Treatment resistance is associated with a significant increase in suicide, which we know is a major public health crisis, as exemplified by this WHO statistic that 1 person dies every 40 seconds by suicide. In the time that it will take for me to do this presentation, 30 people will have died by suicide. We really need to find ways to do better for our patients. That's why we're thrilled to be launching the Stanford Translational Precision Mental Health Clinic, which Dr. Roberts announced. We sincerely thank her for making this clinic possible at Stanford. To our knowledge, our clinic is the first consultation clinic for patients with treatment-resistant depression, utilizing functional MRI as part of the evaluation and treatment planning process. Because this is so new, we will first launch the clinic as a research clinic under an IRB-approved protocol. The process will involve a comprehensive psychiatric evaluation, and testing may include standard blood work, inflammatory markers, pharmacogenomics, neurocognitive testing, and structural and functional MRI. We'll then prepare a feedback report with the data from all forms of testing. You'll hear from Dr. Wintermark in the upcoming presentation about the steps that will go into the preparation of this report. We will then review feedback with patients and suggest possible treatment options. If eligible, patients will also have the opportunity to enroll in our biomarker guided trials, which I'll mention in a moment. So in the center, we've been focusing on testing targeted treatments for two subtypes of depression that we refer to as anhedonic and cognitive dysfunction subtypes, because they don't respond well to conventional antidepressants, and they are associated with an even higher risk of suicide and poor psychosocial functioning than other types of depression. So I'll start with the anhedonic subtype of depression to give you a sense of anhedonia if you have not experienced it before, which I hope you have not. Please think for a moment about things that you love doing or that bring you joy. For example, spending a day at a warm beach with a refreshing breeze, your child's beautiful smile, or some delicious chocolate. Now imagine not having any enjoyment of these activities and the lack of motivation and guilt that may go along with that. This is what individuals with anhedonia experience. Most simply, anhedonia is a lack of pleasure, but it may also involve a lack of interest and motivation for enjoyable activities. It occurs at a clinically significant level in 37% of patients with depression. There's evidence that anhedonia is associated with low activity of the ventral striatum, which is a key node in the positive affect circuit, which Dr. Williams discussed. So this region receives input from dopamine neurons. The question becomes, how might we target dopamine receptors in the ventral striatum? So it turns out that there's a certain type of dopamine receptors called D3 receptors that are densely localized in the striatum. There's also an FDA-approved drug for Parkinson's disease and restless leg syndrome called pramipexole or Mirapex that preferentially binds to these D3 receptors. There's evidence that pramipexole increases activity in the ventral striatum in healthy subjects. So we conducted an 8-week pilot study of pramipexole in participants with depression and high anhedonia. I wanted to share with you the case of Mo, a participant in our pilot study. His story was featured in Science magazine, and you can see him pictured here with myself and Dr. Williams. So Mo enrolled in our study at the age of 37, at a time when he was in a deep depression with a high level of anhedonia. He had lost his job, he was no longer engaging in activities that he previously enjoyed, and he began to isolate himself. After 8 weeks of treatment with pramipexole, we found that there was an increase in brain activity in that key reward region, the ventral striatum. Along with this, his depression level improved from moderately severe to remission, and there was an early decrease in symptoms within 2 weeks. Also, his anhedonia decreased by over 30% from the maximum level. his suicidal thoughts resolved, and his sleep improved. He had a very eloquent way of summarizing the change. He said, "The color has come back into my life. I enjoy music and food again." So now turning our attention to the other subtype of depression that we've been focusing on. As many as 90% of patients report cognitive impairments, and 38% show deficits on objective testing. In the large international multi-site study of biomarkers in depression that you heard about from Dr. Williams, poor performance on a cognitive task was associated with low activity in a key region of the cognitive control circuit, which Dr. Williams and Dr. Tosi have beautifully described. This region is the dorsolateral prefrontal cortex, shown here with the circles. It's important for executive functions such as planning and working memory. So how might we tailor treatment to a cognitive subtype of depression characterized by low activity in the dorsolateral prefrontal cortex? Well, we know that there's a high concentration of something called alpha-2 receptors in the DLPFC. And there's an FDA-approved drug called Guanthacin, which selectively binds to alpha-2 receptors and strengthens the connections in the prefrontal cortex. Guanthacin is FDA-approved for ADHD and hypertension under the brand names Intuitive and 10x. It has been shown to improve performance on a working memory task and increase activity in the dorsolateral prefrontal cortex in patients with mild traumatic brain injury. In collaboration with Dr. Banstra, a psychiatrist in the department, we ran a pilot study of Guanthacin in depression. I'd like to share with you one of the cases. Mrs. A is a 52-year-old female who was currently in a major depressive episode, despite currently taking an antidepressant and an augmentation agent. She reported to Dr. Banstra problems with motivation and concentration. She said, "I haven't been able to concentrate on work for a month now. I haven't put out anything productive. I find myself easily distracted." Dr. Banstra prescribed 1 milligram of Guanthacin daily for a week to get her used to the drug, and then increase this to 2 milligrams daily. Over the course of the 8-week study, Mrs. A's depression decreased from a moderate level to a level that is considered in remission. On objective testing, assessing a measure of planning, that Mrs. A revealed that Mrs. A had a substantial improvement in this measure. Most importantly, Miss A had the motivation to return to work during the pandemic, even when she didn't have to, and was able to focus on projects again. She also had the motivation to start planning a vacation. She continues to take Guanthacin 6 weeks out and continues to do well. So we're thrilled to be launching what we call the Biomarker Guided Study of Depression later this year. What we plan to do is recruit subjects with anhedonia or prominent executive function deficits that either have high or low activity in the ventral striatum or the prefrontal dorsolateral prefrontal cortex. We'll then randomize each group to pramipexole or Guanthacin or placebo for 8 weeks of treatment. We hypothesize that we'll see more change in the ventral striatum or prefrontal cortex activity in the low baseline group, as well as greater improvement in cognitive performance, symptoms, and quality of life. So during this presentation, I've discussed pramipexole and Guanthacin for 2 subtypes of depression. In the center, we are also looking at other novel and experimental therapies for specific subtypes of depression. For example, I'm a clinician in the Precision Neuromodulation Clinic at the Palo Alto VA, and we have a study examining the effect of transcranial magnetic stimulation, or TMS, on cognition in depression. In the clinic, I also helped recently launch intranasal esketamine as another treatment option for veterans with treatment-resistant depression. This therapy may be particularly helpful for depressed patients with dysfunction in the default mode network. While there is evidence that the psychedelic MDMA may be helpful for dysfunction in the negative affect network, which you've heard about from Dr. Williams. In the center, we are running studies of ketamine and soon MDMA in healthy subjects to help us understand more about how they alter brain neurocircuitry in an effort to eventually be able to tailor these treatments. So I'm delighted to let you know that Dr. Williams and I have co-edited the first textbook on precision psychiatry, and this will be coming out next month. We are fortunate to have had multiple leaders in the field contribute to this book. This book highlights the current and potential applications of multiple tools, including cognitive testing, inflammatory markers, and of course, neuroimaging into the clinic. With that, I'd like to thank you so much for your attention. I'd also like to express my sincere appreciation to the participants, our funding sources, my mentors, several of whom are here today, including Dr. Williams, O'Hara, and Wintermark, and our wonderful lab members who are pictured here with their favorite animals, and of course, to our incredible director and the person who made this center possible, Dr. Williams. As others have highlighted, we very much welcome your participation and partnership. Thank you again for your attention.
Thank you, Dr. Hack, for sharing your exciting pilot data and plans for innovative biomarker-guided trials for subtypes of treatment-resistant depression. We'll now move to the Q&A portion of our program, and if you have any questions, please add them in the chat. We actually have one coming in for you. Would focusing too much on the brain be a disadvantage to depression research?
Yeah, thank you for that question. So I just wanted to emphasize again how we're really taking a holistic approach to this and incorporating a number of different measures into our consideration of potential treatment options for patients. And so, you know, I definitely do understand a concern about too much focus on biology, but I want to emphasize that in the assessments that we're going to do of patients in the clinic, it's going to involve definitely talking to the patients and you know, all of the standard things that we do in psychiatry in addition to the brain. So I really think that that combination is going to help move us forward in psychiatry. And just one other study to mention was that was actually conducted at Stanford, where researchers found that patients really would be interested in hearing about their brain measures, and this they felt like this would lower stigma, help them understand their condition better, and then of course, ideally help guide treatment decisions.
Thank you, Dr. Hack. We have time for one final question, and then we can ask some others in the panel discussion. Thanks for your excellent presentation. What is the data for using Wellbutrin for anhedonic depression?
Yeah, that's a great question. So there is data that Wellbutrin is helpful, but the issue with it is that it's not targeted or specific. And so we hypothesize that pramipexole may even be more helpful for a subgroup of people who really have both the anhedonia as well as dysfunction in the ventral striatum.
Thank you, Dr. Hack. Thank you again for your presentation and answering our questions. We'll ask some more in the panel discussion. I'm delighted to introduce our next guest, Dr. Max Wintermark, Chief of Neuroradiology and Co-Director of PMHW. His expertise is in clinical translation of advanced neuroimaging techniques. He has played an integral role in translating the center's mental health imaging pipeline to the clinic at Stanford. He joins us today to present on the clinical translation of a new mental health neuroimaging pipeline. Without further delay, I welcome Dr. Winnemark.
Thank you, Osna. Thank you for the kind introduction. It's my great pleasure to be one of the participants to this anniversary symposium today. The first thing I wanted to mention is I started at Stanford 7 years ago, and as I was starting, Stanford Neurosciences had an initiative about big ideas. And I got to discuss with one of the leaders of that initiative, Brian Wandel from the Department of Psychology. And I'm eternally grateful to Brian because he recommended that I talk to Dr. Williams, who had started a little before me. And I followed his advice, and I got to meet Dr. Williams and to learn about the great work that she's doing. I also got to meet with the absolutely wonderful team that she has assembled. And I got to learn about this revolution that she's leading in the field of psychiatry with the incorporation of neuroscience, neurocircuit, and in particular, imaging in the management of patients with depression and other types of psychiatric disorders. It really caught my attention as well as my interest, and it piqued my curiosity because that's something that I'd been involved with in other fields, also involving neuroimaging. To mention one, brain tumor imaging we used in the past to obtain very limited imaging that basically told us very little about the biology of the tumor. Basically, we would see how big the tumor was, as well as how much edema there was around the tumor, and that was it. But in the last decade, we have seen the introduction of new neuroimaging techniques that are able to look at specific aspects of the function of the tumor. Like, for instance, here on that slide, you have a demonstration about how the brain tumor receives its blood supply. And it's something that allows you to differentiate between different types of brain tumor. It's also something that allows you to differentiate a brain tumor from brain tumor mimics. And it's something that can also help you determine very early if a certain treatment is effective against a specific type of brain tumor. So all those things that I learned from Dr. Williams about depression and about the role of neurocircuits in depression really resonated with what I knew from other fields. Dr. Williams was very kind to accept me as a collaborator, and we started working together on this project of clinical translation, also with Dr. Hack. My contribution to that overall effort is the experience with imaging and with imaging individual patients. And that's something that you need to think carefully about, because there's a big difference between imaging a large number of patients as part of a research study on the one hand, and on the other hand, imaging an individual patient and then using the information collected in that individual patients to make treatment decisions. Those two things are quite different. When you image a very large number of patients, then you have a lot of statistical method, and Dr. Totsi described some of those methods to you. You can basically take advantage of the large data set that has been collected, and you can extract some information that is going to give you a lot of information about the group of patients that you have enrolled in your research study. On the clinical side, on the other hand, we're dealing with individual patients. And so we need to make sure that the quality of the information and the quality of the imaging information in particular is of the same level as the one that you would obtain as part of a research protocol. And you need to make sure that it's reliable if you want to be able to use it to make informed treatment decision. Again, that's something that we have experience with in neuroimaging. I'm going to give you another example, which is the example of stroke. So the management of stroke has changed quite a lot, has evolved and improved quite a lot over the last decade. And in parallel, the neuroimaging that we obtain in patients suspected of stroke has also evolved quite a lot. In the past, at the beginning of the last decade, basically when a patient would be admitted in the emergency room with a suspicion of stroke, we would just obtain a non-contrast head CT. And the goal of the non-contrast head CT would be to differentiate whether we could see a hemorrhage causing the stroke versus whether we could not see anything causing the stroke. And that didn't necessarily tell us that it was a stroke causing the patient's symptoms. But again, that's the tool we had. It was the best tool that we had available at the moment. And you need help in a certain degree by differentiating those patients who had an intracranial bleed from those patients who didn't. And that information was used to select those patients without an intracranial bleed for treatment called TPA. And that TPA could be administered between 0 and 3 or 0 and 4.5 hours, which is a very narrow time window. Then we had a very large number of clinical trials that were conducted using new drugs, also using devices to remove those clots that are causing strokes. And those different trials that were positive basically allowed to increase the time window to treat stroke patient up to 12 or even 24 hours, really suddenly increasing the number of patients who can benefit from treatment and massively improving the outcome of these patients. But as you can see, all of those new trials came with new imaging criteria and new imaging requirement. And so in order to administer those new treatments, you couldn't just get your non-contrast head CT anymore. We needed to get more complex neuroimaging done, involving not just only CT, but sometimes also MRI, and involving, again, the imaging of some functional aspect of the brain, the way the blood circulates in blood vessels, the way the brain gets its blood supply. And again, all those different trials involve different imaging criteria that require the performance of more complex imaging techniques. And that's something that we worked really hard at Stanford and elsewhere to try to implement in our clinical practice. It involves different efforts. One of them, just to give you an example, is one of those targets that you can aim for in a patient with stroke is what we call the penumbra. The penumbra is the brain tissue that is suffering from this clot that is causing the stroke, but that is not dead yet, and that can potentially be salvaged if you remove the clot in a timely manner. The way this penumbra works is extremely complex, and there have been multiple studies that have been conducted at multiple levels. But when we treat acute stroke patient, time is of essence. We tend to say time is brain. And as a result, we need to quickly get at that piece of information. We need to quickly determine if a patient has this penumbra, this salvageable tissue or not, because that's going to influence whether they would benefit from those new treatments that I mentioned earlier. And so that conducted us to develop operational concepts. So we use imaging. The imaging is not perfect. It doesn't necessarily give us insight in all the metabolism and the pathophysiology of that penumbra, but it gives us some useful operational information that can help our neurologist and our emergency physician make a decision in terms of whether they want to treat the patient or not. And just to show you what it looks like, it looks that way. So you have we get first some vascular imaging. We inject some dye in a vein of the patient, and we image that dye when it crosses the arteries in the brain. And you can see that this patient has basically here what we call a filling defect. So there's a vascular segment that is not filling up with the dye, and that tells us that the clot is located in that location. That's a first very important piece of information, because we can see that the clot is proximal and can be reached by one of those retrieving devices that I mentioned earlier. And then we get perfusion imaging of the brain. And the perfusion imaging of the brain allows you to differentiate the tissue affected by that clot that we see on the vascular imaging that is already dead. That's the red tissue, from the green tissue, which is basically the salvageable tissue. It's the tissue that's suffering, that eventually is going to die, but that you can save right now if you're able to remove that clot in a timely manner. So coming back to depression and psychiatric disorders, we face now a similar challenge. There were several questions in the Q&A about obtaining an MRI, and especially a functional MRI, prior to deciding a treatment for patients with depression. You also heard from Dr. Totsi that it's a lot of data that is being collected. It's really 3D images obtained over time, so it's actually 4D imaging. And so what are the solutions that we are thinking about and that we have put in place in order to be able to offer that test on a clinical basis? So we have thought about that quite a lot, and I'm going to go through the different things that we have put in place as a safeguard. So the first one is, in addition to the functional MRI, we're also going to get some structural imaging. The structural imaging is currently being obtained sometimes in patients with some psychiatric disorders, especially in the emergency setting, in order to exclude an organic cause to their psychiatric presentation. And so that's something that is quite important to continue doing. So that's something that we will continue doing. It's also important to know because when you have one of those organic cause underlying the patient's symptoms, it might potentially interfere with the interpretation of the functional MRI. The functional MRI results may be different than they should, not necessarily because the neurocircuits are involved by the psychiatric disorder, but for instance, because the neurocircuits are displaced by this underlying cause. Here I gave you one example. So you have on the top row, a normal patient with normal brain imaging. And on the bottom row, you have a patient with a brain tumor called a meningioma. And you can see that this meningioma is quite large. It compresses the anterior part of the brain, what we call the frontal lobes. It can cause symptoms that sometimes can be confused with those of depression. And again, if you do a functional MRI in this particular patient with this large frontal meningioma, the results are, of course, going to be different and in a good portion because of the mass effect exerted by that large frontal meningioma. So again, in order to be able to detect those organic causes and to interpret our functional MRI with some perspective, we'll add some structural sequences to our MRI protocol. The other thing that we are going to put in place is a process to try to ensure the quality of the functional MRI. Again, as Dr. Totsi mentioned earlier, a functional MRI requires the acquisition of MR imaging data over time. It's very important for the patient to be compliant with the tasks that they are asked to do or not to do. It's also important for the patient, for instance, not to move in the MRI scanner, because if they move, potentially that could affect the results. And so one thing that we currently do for the functional MRI that we do for other types of conditions, such as, for instance, in patients with brain tumor, and that we will replicate for patients who will undergo fMRI for depression, is some kind of education process for the patient. We have indeed observed that for our surgical patients who come for an fMRI before brain surgery because they have a brain tumor, we can increase very significantly the quality of the functional MRI by explaining carefully what we are going to ask them to do during the fMRI. So we have prepared a video, an educational video that the patients can look at home the day before their fMRI. They look at it again on an iPad when they're in the waiting room, waiting for their fMRI to occur. And that training video basically explained them everything in terms of what they should expect from the test, what's going to happen, what they are going to ask to do. And again, when we studied that for our surgical patient, we again saw a very significant impact on the quality of the fMRI data we were able to collect. but also on the time it took to conduct the exam and the overall comfort of the patient, which is something that is extremely important. For our clinical care, we'll also use FDA-approved equipment. So we have a software to obtain the Fmri imaging. We have another software called EdSeri that will be using to process the data coming out of the scanner. And we have set up, and I see Osna showing up on the screen, so I know that I have to go a little faster. So we have also set up a whole quality control process in place to detect different things, to detect, for instance, if the patient starts moving in the MRI scanner. Sometimes patients fall asleep because of the buzzing sound of the fMRI scan. And so we want to detect that early so that we can potentially correct that issue on the spot, as opposed to realizing it after the patient has left the MRI facility. So a whole set of quality control processes. We'll come up also with a report to describe our finding. And I think for that, the main thing I want to say is that it will be integrated with the rest of the information that Dr. Hack is going to collect in our clinic. And again, our goal is not necessarily you get an MRI, you get a result, you know what to do. The situation is, of course, a lot more complex than that. And the result of imaging is true for depression and psychiatric disorders, but it's true in general. The results of imaging always have to be interpreted in context of the other diagnostic tests and the clinical presentation. So we'll make sure that that's indeed the case. So I think I just made it in time. Again, it was a great pleasure presenting today. It's a pleasure working with this outstanding team on this exciting project. And again, if you want to become involved, you have the information here that will allow you to do so. Thank you for your attention.
Thank you, Dr. Winnemark, for the deep dive into this new paradigm shift using circuit dysfunction types to inform interventions. Let's now move into the Q&A portion of our program, and we'll look to questions from our guests. If you have any, please type them into the Q&A section. And in the interim, were there any points that you wanted to touch base on when we can look forward to having this move into the clinic, Dr. Winnemark?
Yes, so we hope to be offering it very soon. It requires a lot of coordination on a lot of different parts. We have been working closely with the medical center. I think there was a question on billing earlier, so that's also an aspect that we are working on, because we of course want to make sure that that test is affordable for patients. It's of course going to be a process, you know, that's why we're translational program. We are going to learn as we go, and also the more experience we gather and the more we can show that our approach impacts positively patients' outcome, the more we'll be able to get traction with payers, reimbursement, and so it will also help really with the widespread implementation of the approach that we're proposing. And again, if you look at what has happened in other fields, that's also the way it goes. MRI in general is an expensive test, but we obtain it routinely for many conditions where it has been shown to improve management and outcome, and we'll hope that we'll follow the same path.
Thank you. We had a few questions. Oh, sorry, we have one coming in the chat. Thank you for your excellent presentation. Do you have any data on retest reliability for functional MRI for resting state and also the active fMRI tasks?
Yes, so that's something also that I didn't have time to go in a lot of detail, but that's also part of the quality control. That's something that we have been working on, and as part of that overall effort to make sure that our results are reliable in individual patients.
Thank you. Any other questions in the chat? Do you look at the oh, I seem to have lost that question. There was a question and I believe we just lost it. Sorry. So a few other questions we have on here. You focus on measuring brain circuits using functional MRI. Do we plan to include other measures like genetic information?
Yes. So for that, I'll defer again. Perhaps we can discuss in the panel discussion. I believe that when Dr. Hack presented all those different tests that she will have available to pick from, in a, again, individualized way for each patient, I think that genetic test will definitely be one of the options that she will look at. And again, she'll be able to explain that a lot more eloquently, but I believe our plan will be, again, to really tailor the test that she picks based on what she thinks is going to have the maximum impact for one individual patient, the patient she's taking care of at the moment.
Perfect, thank you. I believe that is our questions, and we will just take a quick pause in between before we introduce our next speaker. Thank you again, Dr. Wintermark, for your wonderful presentation.
Thank you.
Thank you. So it is my distinct honor to introduce our final speaker of the day, Dr. Ruth O'Hara, Senior Associate Dean for Research, Director of the Stanford Clinical and Translational Science Award, the CTSA, and co-director of our center. Dr. O'Hara has played a major role in fostering an environment at Stanford in which this type of research is possible. We look forward to hearing about the future vision of the center. With that, I welcome Dr. O'Hara, and just bear with me as I share our slides.
Thank you so much. So I just have to say it is an extraordinary honor to be here with Dr. Williams and the extraordinary investigator she has brought to this effort. I'm at a stage of my career where I'm starting to look back and think about the things that I've done that maybe I think were particularly great contributions. And one of the things that I am most proud of is being one of the individuals who was integral to making sure we recruited and brought Dr. Williams on board here at Stanford. I first met Lee over a decade ago when she was here as a visiting scholar, and it was very clear that she was a visionary leader. Today, we're going to talk a lot about collaborations, the essential component of team science for contributing to all that we do in this space. But it always takes one visionary leader to bring it all together. And Dr. Williams is absolutely that individual, and we're so fortunate to have her at the helm. So I was asked a few years ago to give a presentation on what I believe to be the critical challenges facing mental health. And so I reviewed a number of papers and review papers, and I considered this for quite an amount of time. And there were several central themes that emerged. We have a lack of objective measures that has traditionally been a key factor and limitation. We tend to focus on one domain of symptoms. That has certainly been the case in the past, ignoring often other critical domains such as cognition, or psychological stress, or biological issues such as immune and sleep. We have a need for more deep phenotyping, and genetic markers have been elusive. We have insufficient characterization of trajectories of mental health across the lifespan, and a lack of direct access to the key tissue of interest. And that's been really a rate limiting factor. So if we go to the next slide, how can we tackle these issues? Well, we've seen huge innovative approaches over the last decade, but they still haven't got us to the point of realizing precision mental health and wellness. And I think this center is really tremendously well placed to give us exactly what we need in terms of integrative models and technologies, bringing together the interdisciplinary collaborations that are necessary to achieve that, supporting and a role that I can play with translational facilities, and then having state-of-the-art data science and biostatistical approaches. So if we go to the next slide, I am very much trained in what would have been called cognitive psychology and is now actually called cognitive neuroscience. So when I started, I was very struck at the early stages of my career that we saw cognitive information processing as very distinct from other aspects of emotional processing. So in many fields, it really was not considered okay to really speak to emotion and cognition at one time. And so what has happened is that we've started to learn over the past few decades that actually cognitive functioning and information processing systems, and you've heard so much about that today, are integral to our ability to tackle mental health. They are integral to the profile that an individual presents with when in fact they have a mental health disorder or set of symptoms. So if we go to the next slide. Integrating and cognition, we start to realize, has really become essential for understanding mental health. And the advances over the past few decades have showed us that we absolutely need to consider cognitive information processing at the same time, because not only are they related, but they're subserved by the same neurocircuitry. And this comes up in multiple examples. You've seen many of them here today, but in particular, there are many advances in terms of understanding how this is not only important for understanding the etiology of mental health disorders, but also for understanding treatment response. So one of the things that was really striking to me when I met Leanne Williams was that she really understood the importance of the cognitive profile in terms of better characterizing psychiatric symptoms. And that was just very innovative to meet somebody who really understood the cognitive component as an essential feature. So, the next slide is actually referring to work that we have done in my shop. If we go to the next slide, Fausta, on the importance of cognition, not just in terms of understanding etiology, as I mentioned, but also in terms of understanding treatment response. So we were very struck by the fact that older adults have core symptoms of depression that include, of course, often cognitive dysfunction. In particular, their executive functioning, their ability to organize, to strategize, seems to really take a hit as they get older. So one of the issues is, they become less responsive to certain types of treatment. So we had a cognitive behavioral trial, and we thought that it would be particularly important to examine if the individuals who are less responsive to CBT might in fact be those with cognitive impairment. It seemed like a very logical hypothesis. But in fact, what we observed was quite the opposite. We observed, in fact, that individuals who had the poorest executive functioning were the most responsive to CBT in terms of their depressive outcome. And this was really something we were not anticipating. We were very surprised. And we wondered, in fact, if it was because cognitive behavioral therapies actually shore up the response to treatment. If you have a lack of organization, you're having struggles planning and strategizing, cognitive behavioral therapy may actually augment those strategies for you. And so they kind of provide a scaffold for older adults who would otherwise be struggling with those components, making both the treatment and their day-to-day life and problem solving more manageable. So this was really a very important finding where we could recognize that, in fact, even when cognition is impaired, it may be that the particular treatments under consideration have, in fact, a significant positive impact. We go to the next slide. What's curious, of course, is that the same cognitive component and the treatment actually has an impact on the response. So in a pharmacological trial done by Yvette Chalene at UPenn, she found actually a very different effect. She found that speed of processing, slower speed of processing, how quickly you actually encode certain types of information in older adults predicted a poorer response to treatment. And she independently found that brain structure, hippocampal volume, also predicted a poorer response. These were the individuals who are much less likely to achieve remission following 16 weeks of sertraline. And this showed us that it depends which cognitive component we are considering, and it also may depend which treatment we're considering, be it pharmacological or behavioral, what the role of cognitive processing will play. And this started to get to the notion that Dr. Williams has led us on this path of biotyping, that it's not as straightforward as saying, well, if your cognition is impaired, you're going to have poor treatment response for depressive symptoms. It's actually that it's contingent upon the type of cognitive impairment, and also that there are other components such as brain structure and function that may be vital. Next slide. So our conclusions were that cognitive dysfunction may be a significant risk factor for not only treatment response, but also even the development of psychiatric illnesses. That these dysfunctions exacerbate our psychiatric symptoms. And they not only impact our pharmacological and psychological treatments, but they allow us then to actually have a potentially effective treatment for addressing depression through a variety of augmentation and rehabilitation approaches. Next slide. So one way that we've been doing this is actually by looking at brain imaging measures of the response to a treatment or a training plan that actually engages the elderly adult in bolstering their cognitive performance, training them to achieve a better performance in terms of both their cognitive processing, and then looking and seeing that, in fact, this has a very positive impact on prefrontal cortex, the anterior cingulate, amygdala, and also insula. This is just a very important contribution and offers us a behavioral augmentation and rehabilitation approach, but it also offers us an opportunity through transcranial magnetic stimulation, an augmentation or approach to actually enhance those domain areas simultaneously. So executive function tasks we find improve when, in fact, we increase the performance by getting people to practice their focus, their inhibition, their task shifting, their working memory. It's really a very positive benefit. Of course, enhancing cognitive function and has an immediate positive benefit for the emotional regulation. And we have seen that both at the neuronal connectivity level and also at the behavioral level. But those are not the only aspects of training that we can engage in. If we go to the next slide, we find that actually experience shapes our behavioral and neuronal response. So engaging multiple systems, including physical systems, such as exercise, as well as cognitive training, and as well as actually emotional regulation itself, we can enhance the performance by augmenting practice on emotional regulation tasks and coming at the individual's response to treatment, improvement in terms of their symptoms, can capture a variety of approaches that actually augment, in turn, the ability to enhance symptoms and to improve mood. This is a multi-approach that the center is really pivotal in bringing together individuals across multiple domains who can achieve this kind of integrated hybrid approach to improving mood. Next slide. I am particularly interested in life course And life course is very important in terms of cognition. Cognition is one of the most common components of function that declines with age. It is in fact often self-reported by older adults to be the most more perturbing to actually be suffering from impaired cognition with age than suffering from physical disorders. We have collaborated with multiple groups to show that not only can you enhance cognitive functioning through cognitive training, but exercise is a particularly valuable approach to improving the connectivity among neurons and to also improving not only cognition, but one of the most beneficial components for mental health, particularly depression. So making sure that we're capturing cognition and emotion together, not just at one point in the lifespan, but across the lifespan, is really a sort of state of the field aspect of what can be brought together in the center. Next slide. Another domain of research that has underscored for us how cognition is related to emotion was in work that came out in the mid-2000s on the relationship of the serotonin transporter polymorphism to stress and depression. In the mid-2000s was an era when we were very excited in psychiatry that we had actually several candidate genetic markers that would give us more precision around our ability to define who is at greatest risk for developing which mental health disorder and responding best to treatments. The serotonin transporter, if we go to the next slide, is integrally involved in the efficiency of transcription. The short allele in particular, they're just two, short and long, it seems to moderate and modulate serotonin reuptake. And in the case of the short allele, this is diminished. And that can result in extracellular levels of serotonin in the synaptic cleft, which is actually potentially neurotoxic in some cases. So this was a very important finding, the relationship of this particular short allele to increased risk for depression in the presence of stress. But what was very curious in our group when we investigated this, if we go to the next slide, is we found that the serotonin transporter short allele was also integrally related to delayed verbal recall and also waking cortisol levels, which are the stress hormone. And these two in interaction really conferred a significant decrease in verbal memory. So it further underscored for us that in fact, having the short allele put you at increased risk, not simply for depression in the presence of stress, but also impaired cognition, leaving open the question of whether in fact the cognitive effects are mediated by stress, or in turn, whether the emotional effects are actually mediated by impaired memory. So this was really a striking finding. I had a very interesting conversation with Leanne Williams at the time, because if we go to the next slide, we moved to a model very quickly of moving away from candidate genetic markers and moving to a model, of course, of whole genome sequencing, a much more in-depth and robust phenotyping of the genome, and trying to grapple with that at the individual level. But we sort of ignored and stepped away at that time from candidate genetic markers. And I talked to Dr. Williams about this, and I think it's a measure of her vision that she really understood that the contribution that even these broad candidate markers could make to our biotyping, and that we held ourselves in psychiatry often to a higher standard for identifying potential biomarkers, particularly as they work with other domains of symptoms and cognition. And that was, I think, a fundamental building block of the thoughts for putting together the center. So if we go to the next slide, team science is, of course, essential to building a center approach. to gain the complexity of insights that we need to integrate these domains. And Dr. Williams was already at the forefront of trying to do that. While we might employ candidate gene markers that have been well documented to impact psychiatric functioning, such as the 5-HTT-LPR or APOE in the case of cognitive impairment and cognitive decline, I have to say that she had the vision to recognize that we need to bring these all together at the same time in the same individuals, and that this could be utilized to produce a biotype that might far better inform us in a more precise manner, really achieving the goal of precision mental health. And to that end, she's brought tremendous numbers of individuals here, together a fabulous investigative team, many of whom are tackling the specific domains, but also integrating them with others. So one of the biggest challenges in the field of mental health is actually getting back to the level of the cell. So the basic science approaches in mental health have often remained distal from the brain and the behavioral phenotyping. So if we go to the next slide, one of the challenges is how do we get further into the brain neurocircuitry at the cellular level and the neuronal functioning to better understand what particular aspects of that functioning is in fact bestowing an increased risk for the development of a psychiatric disorder, or telling us who is going to respond better or not to treatment. And this has been one of the biggest challenges compared to other fields, unlike cardiovascular medicine, for example, unlike the domains of oncology. We in psychiatric disorders do not have direct access to brain tissue except under the most extreme of circumstances, when somebody suffers a traumatic brain injury, for example, or when they have a premature passing due to suicide, which is really one of the most troubling components of depressive disorders, is in fact the risk for suicide attempt. So how do we get down into the cellular basis to better understand the etiology of these disorders? And it's important to recognize one of the reasons it's so important to have access to the brain tissue that we are really looking at as part of the organ of interest is in fact to be able to understand how the genes express. Gene expression is tissue specific. So this is a real important component that had been significantly rate limiting in the field of psychiatry. If we go to the next slide. So we did a study actually on older adults who were coming in for a CBT, and we looked at their responses, their brain imaging responses to CBT while in fact engaged in an executive functioning task. And we found that these were very heterogeneous. So on the one hand, we use brain imaging to try and define what's going on. The sample sizes we would require to understand at a cellular level are actually significantly high. Often, this is not something that's feasible. So even though the findings here were that certain patterns, and if we move on the slide, actually of brain imaging, particularly in the prefrontal cortex, were predictive of treatment response to CBT, there were so many variations that it would be very challenging to create a biotype from this information. Next slide, please. So we recognize it's really important to have a multimodal and dimensional approach to understanding psychiatric disorders. So in the last decade, in 2007, moving to the next slide, we had one of the most significant advances in the field of psychiatry, which was the ability to utilize induced pluripotent stem cell models to derive neurons and examine the function of those neurons in a dish. This has been a model system that has been adopted in every domain, But it's particularly important for us in psychiatry because we have the opportunity for the first time through just a simple blood draw and very complicated techniques subsequent to that to actually derive from that blood sample the fundamental stem cells from which all other cells are derived and grow up neurons from the individual patient that we are actually examining in a clinical trial. And in fact, if we go to the next slide, one of the most valuable components of growing up neurons from our patients with these psychiatric symptoms is we can also examine in the dish the response to various treatments. Here's wonderful work from Fred Gage and his group on altered serotonergic activity in individuals with treatment-resistant depression. This is a model that we have adapted in our own labs here, and we go to the next slide. We have an ability here to actually derive eye neurons. There you can see these are eye neurons from individuals who have participated in our studies that actually show activity. This is calcium imaging to show that these neurons are actually synchronous and showing spontaneous network activity. It's a really powerful model. It's not a complete model. It's a model that's still in works, but we are already finding very significant opportunities to examine many of the theorized and hypothesized etiology of something like depression or anxiety in the dish. In fact, one study in the next slide you'll see that we're doing is a stem cell model of examination of stress response in depression. So we have depressed patients and also healthy controls who participate. We derive the neurons. We actually grow them up over 28 days. And then we're able to examine the gene expression from those neurons with and without exposure to stress hormones. And this is also a model that facilitates treatment with multitudinous treatments that will be extremely beneficial for really bringing tremendous link between the cellular level and the clinical level in real time. Next slide. So just probably can't see this because I'm not sure the videos are working, but for some of our older adults, we already have this stress model. And these are neurons that if you press on the video there, you can see are actually firing synchronously with each other from a participant in a study. And this is just a tremendous opportunity to be able to get a cellular level at the same time as we're achieving the imaging, the cognition, the emotional regulation, and the clinical symptoms. Next slide. So where do I come in terms of my role in contributing to the evolution of this center? Well, in addition to having teams, we also have to have facilities and resources. I am the leader of the CTSA, which is our Clinical and Translational Science Award, funded through the NIH, that brings a tremendous number of opportunities, facilities, instrumentation to our research teams across the School of Medicine, and in this case, specifically to support the work of the center. We have so many opportunities here, if we go to the next slide, where we can really contribute tremendously, I believe. We have new cryo-EM machines that are being deployed as we speak. We have the latest and greatest in many genetic domains, full whole genome sequencing through our core facilities. There is a smorgasbord of resources that often I think we are not always as good at communicating about as we could be. We also have a tremendous amount of opportunity to engage with individuals working in domains such as compliance, to understand and have support for the mechanics and the administrative components of organizing and supporting clinical trials. Our clinical trial platform has grown tremendously in the last decade here at Stanford. Next slide. We have a clinical and translational translational research unit, where you can actually go and get an approach with bringing your patients, having your patients have blood drawn, have the assays performed that you need, have the DNA stored, have nursing support, research nursing support for those studies. And we will certainly be providing those resources here for the Center for Precision Mental Health and Wellbeing. Next slide. This is our clinical research unit, where there are clinical research coordinators who are able to engage with and produce a much more rapid process for getting that all-important IND, for having financial support in terms of what's the contracts that need to be signed, for supporting recruitment, for supporting scientific review. These are all of the resources that we currently offer. And really also underscoring the compliance components. It's often the more boring stuff, but it's the essential stuff for creating good centers. Next slide. We have a precision health biobank. This already supports over 100+ faculty projects, while also helping advise Stanford as to the next generation of life science data solutions. It's an excellent biobank, and it was integral, if we go to the next slide, in helping us achieve and be at the front lines when it came to actually taking specimens with respect to COVID-19 and getting a much better understanding of infection recovery. This is one of the IRIS neuro study was at the forefront of nationally. And as a result of that, we in the biobank really got a tremendous amount of additional recognition and support because of this win-win collaboration. One of the other components, and I mentioned it as my fourth component, is the essential glue to having this integration among multi-models, multi-dimensional data, deep phenotyping, to bring that into a pipeline that can be operationalized to improve clinical care and treatment, actually requires state-of-the-field bioinformatics. And this is a domain also in which psychiatry has been behind our other domain areas, such as cardiovascular medicine, oncology, to name a few. We have tended to be very cautious about moving away from a hypothesis-driven approach to a data-driven approach. The amount of data that we have here to integrate and to yield precise phenotypes that capture everything from the cellular level, the genome, the neuroimaging, the EEG, the clinical profiles, the cognitive profiles. We need a significant data science, data-driven approach. And we have excellent collaborators here. Sylvia Pleveritis in the Department of Bioinformatics and Data Sciences has an extraordinary faculty, always eager and interested in bringing their expertise to these issues. We have, as part of our clinical, our informatics core, we have Nigam Shah, who is renowned for actually developing bioinformatic approaches that can bring together clusters of phenotypic information that can give us much more precision about how a particular patient is doing, what their prognosis is, how they're responding to a treatment or not. And I think it's a very innovative component of the Stanford Center for Precision Mental Health and Wellness that we are actually heavily engaged with really state-of-the-art, nationally and internationally, experts who can help us have the techniques from a bioinformatics perspective that will allow us to optimize the biotyping that we will achieve in the center. And this is just an example of some of the issues that we deal with. You know, even something as simple as design needs that informatics approach. We have shown over the years that if you actually just do a prospective study, there are many flaws with that study if in particularly with the interpretations, if you don't have the information that and the design from a bioinformatics perspective that sets you up to get the best yield on that data. And we found that actually by structuring our designs ahead of time, we yielded more precise and accurate information that gave us a very different picture into the etiology, in this case of Alzheimer's disease, but this can be applied also fully to psychiatric disorders. So with that, I'd like to conclude and say this is a very quick view from 40,000 feet to thank you so much and ask you to join us in creating the future and collaborative mission of the center, taking us from the biotyping right through clinical and field translation. It takes a village, and Dr. Williams has assembled an extraordinary village here, but it's her vision that is the fuel that is driving us and bringing us together, and we're extremely grateful for that. Thank you so much, and apologies for the glitches at the beginning.
Thank you so much, Dr. O'Hara. We really appreciate you presenting today and showing us what is to be expected of the center and our future vision. We will move into the panel discussion portion, and I'll have all of our presenters join us back. Thank you again to our esteemed speakers. We have spent the morning navigating the roadmap to precision mental health and have learned about not only the innovative work the center has accomplished thus far, but the future vision of translating this work to the clinic. I look forward to moving into our last segment and learning more from our speakers and answering some more of your questions. With that, we have a question from the audience. Are you recording interviews of subjects/patients and developing measures in review of these, of this information, processing and idea feeling integrative functions? And I kick that off to either one of you who would like to answer. Laura, perhaps you can answer that question.
Sure, yeah. At the moment, we're not doing any recording of interviews, but it is definitely something that we may consider in the future. Appreciate the question.
Thank you. Hello, Dr. Totsi. Follow-up question. Follow-up question to your talk. What stage is the Human Connectome project at right now? What kind of data does your team have now versus what you are still discovering? Thank you so much.
Thank you for that question. Right now, the Human Connectome project has completed its first large phase, which was collecting a very large number of data sets from healthy participants. And now the data collection part for for clinical populations is nearing completion. After that, the data will all be pre-processed and processed centrally, and then it will be shared openly for the scientific community. So right now we're in that stage where the clinical data is finishing getting collected and is getting ready to be processed and then shared.
Wonderful, thank you. Our next question, thank you all. Thank you for all of your excellent presentations. What are the data for retest reliability for resting state functional connectivity in longitudinal studies? For example, retest reliability over 8 weeks.
Leonardo, do you want to tackle this one?
Oh, sorry. I think Dr. Williams was getting ready to answer. So I can start just by saying, we do investigate retest reliability a lot. As a matter of fact, one of the studies I've shown might be answering your question directly regarding resting state functional connectivity longitudinally specifically. So we did study longitudinal retest reliability for our resting state measures. And, there are similar studies, and we're doing similar studies for, for other types of data.
Wonderful, thank you. I have a question for Dr. Williams. Your precision brain circuit method is currently tested for depression and anxiety. Could it be applied to other areas of mental health and mental health disorders?
I'm really glad that question has come up. The short answer is yes. I expect that we'll need to characterize additional circuits, but because these circuits are ones that govern emotional and cognitive and like self-reflective functions in the human brain, different types of dysfunctions in those circuits may also characterize additional conditions, such as disorders of involving psychosis, other mood disorders, including bipolar disorder. We do have studies underway in younger people with attention problems. So yes.
Thank you. We have another question from the audience. Thank you all for your excellent talks. I may have missed this, but how exactly are patients classified into putative biotypes? Is this a weighted combination of presenting symptoms and connectivity values? And then how are thresholds for determining hyper versus hypoconnectivity or activation? And are there thresholds computed at the individual level only? And then the third part to that question is, are any other biomarkers included in biotype classification? For example, inflammatory markers, genetic or epigenetic profiles?
Maybe I should take that one. And if there is a contact email for the person who's asking the question, we'd be happy to send papers that give more detail, because it's a really important question. And there's several layers to the answer. Right now, when we're talking about biotypes, we do anchor those in quantification of the brain circuits, but in doing so, we are establishing and have established which of those are relevant to the symptoms we're talking about and how they're affected by life experiences, say early life trauma. We do quantify people at the individual level, and we do so compared to standardized normative thresholds. And there's an ongoing process of refinement, like there are in other areas of health, which will establish to what extent, when we add inflammatory and other markers, can we gain precision. And one small example, which I could send in a paper, is in that cognitive control circuit, which typically predicts non-response to, for example, citalopram. There's one genetic variant that, if we know about that, a very, very small subset actually go the opposite way, and they do benefit from the treatment. So there are refinements to come and a need to combine information as we go.
Leanne, could I add to that?
Please. Yes.
Just to build on the last set of slides on the data science approach, I think sometimes it's very hard to guess to, particularly with those aspects of function that we have not traditionally integrated into our models. So having some of the data-driven approaches to help us better define some of those thresholds. To go back to the example where we found that poor executive function in older depressed patients predicted better treatment response, we didn't guess that. And we might have set different thresholds where our hypothesis to be proven and where we actually to go with that information. So it's really important, I think, when we're bringing so many multiple domains together, to actually have a data science approach, a data-driven data science approach to characterizing as best as possible where those thresholds might be residing, because it's not always where we think they will be.
Thank you, Dr. O'Hara. So we have a few more questions in the chat. Thanks so much for the great symposium. Do you see using methods from casual inference to precision mental health? If so, could you please elaborate what might be the challenges specific to mental health and wellness? Thank you.
I'm wondering does anyone want to take it? I think they're asking about causal inferences. Would that be, is that the question? postulated? Is it causal?
Yes, sorry.
So please jump in, anyone else who wants to answer. I think understanding the causal chain of effects is really crucial, and that's necessary for also understanding what constitutes risk and what we can use for prevention. So the way that we're tackling that now is through our treatment studies, where we're actually asking if we know about the baseline state, and then we deliver an active treatment versus non-active, a placebo or comparison condition. Do we see changes in brain and symptoms and experience that we can explain causally to the extent that we have an experimental control? What is needed by our field is much more intensive longitudinal studies where we can really track whether to what extent changes are predictable and causal based on experience and interventions, and which are more state-like. I don't know if Dr. O'Hara, you wanted to add.
I think you're on mute, Dr. O'Hara.
I think you hit the nail on the head, Lee. The mechanistic trials that you are aiming to achieve here will be essential for giving us a better understanding of the etiological path. And I think in particular, by having such a comprehensive set of domains that the center will cover and consider, that you are optimally placed to really provide key insights into those different etiological pathways. I think one of the things when you talk about the longitudinal that's particularly critical there is we have to recognize there are significant changes across the lifespan. And it's really a strength of the center that you're embracing the lifespan approach, because information we may get for somebody in their 20s may differ very substantially by the time they're even in their 40s. So I think the center will contribute in a very significant way to starting to hone to some of these pathways that have eluded us a little bit, because we have this single snapshot. By trying to have both more comprehensive assessments, coverage, multidimensional approaches, and then recognizing that these two change over time, I think is a huge strength that will enable you to achieve the vision of the precision mental health.
Great, I think we have time for one last question, and then we'll try to answer the other questions in the chat following the end of our presentation. So I have a question here about, I appreciate the quality control efforts with task-based fMRI tasks, but I wonder if the precision mental health routine in the future would still use them, given how difficult they are to conduct, and given that resting state fMRI appears to contain the full repertoire of functional dynamics normally captured during various types of tasks. And then they quote a literature from Smith et al.
Maybe I could kick this one off and then ask others to jump in. This again is a fundamental issue for our field, and certainly the work by Smith and others shows how well the resting state data characterize these brain circuits at rest. What we are finding in other labs is it really is important to know about how those circuits change in response to a task if your interest is in predicting treatment response and how you change to treatment. So far in our data and other labs, the resting state data gives you a general indication of whether someone's likely to respond or not, but at least so far is not differentiating between treatments. And we could think of analogies in other fields where you may get information that's crucial from, say, resting heart rate, but you need to know how it changes in response to stress, like a stress test analogy, to really get into the weeds of like what is changing in response to pushing the system, in our case, pushing it with a task. So thanks to Dr. Wintermark, and you may want to jump in, we have found so at least a reasonable approach for delivering tasks in a clinical setting.
Yes. And we are also obtaining resting state fMRI in addition to a couple of task-based sequences to do exactly what Dr. Williams described. It's not your cardiac stress test, it's your mental stress test.
Would anyone like to add? Such an important question for our field.
Just adding on to the part about how difficult they are to conduct the task-based fMRI, I agree with that, but I'd have to say that a shout out to Dr. Williams. She has thousands of patients that she's done these tasks on. So I think that we have a good system down for really having people do them. And I think it's very realistic to do it in the clinical setting.
I might just add something very specific to the way we think about rest versus task as well. So it is true that in the resting state, you can gather some information about network properties of the brain, like grouping, for example, brain regions into networks, and those are relatively preserved during tasks. However, during the task, you also have these networks and these regions also behaving differently. So while it is true you can derive some properties from the rest that are in some way maintained during the task, each task comes also with a series of measures that can only be captured by the task as well. So I would think of those two types of images as complementary, as the other speakers have said before. This is more in relation to the papers that you also have cited.
Thank you, and that will conclude our panel discussion for today, and I will kick off back to Dr. Williams.
So thank you so much for joining us today for the anniversary symposium of the Stanford Center for Precision Mental Health and Wellness. We are already planning for the next year's symposium to share with you the exciting new data that will be available in that time frame. So please join us next year, same time, similar time, September 23rd, 2022. And thank you again for joining us, and we look forward to your partnership on this journey. Thank you.